Okay, our next speaker is Dave Domann, Senior Director, Healthcare Quality for Johnson & Johnson Healthcare Systems. Jansen of Johnson & Johnson is a supporter of our conference today, so just want to thank them again and make sure they have a display outside, make sure to stop and take a look. Dave leads a team responsible for providing strategic direction and insight and regarding the changing dynamics within the U.S. healthcare system in the area of quality measurement and evolving healthcare delivery and payment models. He has, and I think this is really exciting and interesting, served in leadership roles at the National Quality Forum as chairperson of the NQF Supplier Industry Council. He's also serves as a partner on the Health and Human Services Partnership for Patients that's focused on reducing hospital readmissions and healthcare-acquired conditions. He's one of the key authors of a recent Institute of Medicine Roundtable on Evidence-Based Medicine publication on leadership commitments to improve value in healthcare, finding common ground, health product developers. So as you can see, he was a clear choice to join our agenda today. And the title of his presentation is Quality Measurement and Behavioral Health. And after this, we'll move into our panel discussion where Dave will join in a panel. We'll be able to have an extended discussion after his presentation. So thanks for being here, Dave.
Yeah, thank you, April. Yeah, this is my first engagement, with your organization, and I've thoroughly enjoyed the morning. I sense, a commitment to what you're doing, and also some energy. And I will say that even after the last presentation, I think it's a good setup for what I'm going to talk about because the environment is really changing, and I totally agree with everything that Dennis just laid out. I have a chance to work with a group at Johnson & Johnson that's focused on engaging executives across the United States in ACOs, medical homes, large medical group practices across the country, just to find out what's going on and where are they going with this. And it's clear that this whole value-based care train is on the track. There's no doubt about that. We've conducted recently we've done 6 of these so far in the last month, executive insight sessions. And we do an exercise that we call History of the Future, where we start out at 04, we go to 2014, and then we talk about 2024 and the progression of things that could be happening. And it's just an unbelievable exercise when you see, the amount of change that's taken place. I think we've actually probably underestimated the amount of change that's taken place in healthcare so far. What I want to do, well, first of all, these are my opinions. What I want to do is talk a little bit about the quality measurement direction in the United States. I know that your organization has kind of a practice and research direction, so I'm going to try to tee it up in that realm. But talk a little bit about really where value-based care is going and the accountabilities that are coming into play. It's interesting with quality measurement, but HEDIS measures are about 25 years old right now. But I think most people who work in the quality enterprise would say that quality measurement is still in its infancy. We're just expanding from some simple process measures to more, to really address more domains of measurement. And that's actually part of what I, want to try to tee up. And actually make a couple of comments about the National Quality Forum and their Measure Application Partnership, because I think a lot of the change in quality measurement in the United States right now will be coming from what's called the MAP. And I'll talk about that a little bit more. But first of all, I don't know if you're familiar with this term that we use commonly called the quality enterprise, but there's clearly a group of stakeholders in the United States that are driving what's called this enterprise. Actually, Mark McClellan and Janet Corrigan from the National Quality Forum actually coined this and actually drew this visual. But it all starts with setting national priorities for quality in the United States. NQF has led that with HHS. It moves into how the measure developers take those signals from the national priorities, create measures. There's numerous measure developers in the United States, far more than what I've identified here, but clearly, the National Committee for Quality Assurance, EMA, Physician Consortium, and those groups have been kind of leaders in measure development. Once those are developed, they go through what's called a consensus process, that the National Quality Forum leads in a way that's kind of like the good housekeeping stamp of approval on a measure. And usually when that happens, those measures are usually ready for prime time. Now there's a new process that formed just 3 years ago called the Measure Application Partnership. And I'll show you visually why this is important, but really CMS has about 24 to 25 different quality measurement performance reporting programs right now. And there have been issues in the past with what measures were selected for all those programs. So a good part of what the map does is actually determine what measures should we be using in all of the CMS programs. Now there's still issues with lack of alignment with private payer programs in CMS, but hopefully there's some activities going on in that area that will help straighten that out a bit. But then after the measure application partnership, those are ready for public reporting and so forth. And really what I'm going to try to address would be really anywhere from national priorities down to the map. That's the kind of conversation I'll try to have this morning. There's a lot of good things going on, I think, in the mental health area with quality measurement, and I'm not going to talk about all that. I do think there are some leaders like Harold Pincus at Columbia who has laid out measurement domains and suggested a method for measurement of mental health in the United States, and also has recommended a strategy, that talks a little bit about, measure stewardship, talks about standardized measurement, the whole framework for measurement electronically and so forth. So I think there's a lot of good things that have been espoused. It's just a matter of, how quickly, the mental health space can really move forward with a lot of the new measurement that we really need in the United States. And also I would say that SAMHSA, in their most recent Leading Change Action Plan, really had similar thoughts that Harold, covered in his Health Affairs article, related to, the framework for measurement and all of that. So I think there's a lot of good things, pushing, in the right direction. And I'm not really going to go over all the quality measures. I think it's about 50 or 55 that are endorsed by the National Quality Forum right now in mental health. I'm not really going to try to cover that kind of space. When you look at value-based care, and Dennis really had, I think, some great comments here, but what we try to depict in some of the storyboards we use when we do strategic planning is, I don't know if you can see this, but it's a physician basically straddling between a fee-for-service environment and then a value-based payment environment. And at least with this provider, we're depicting, and you can't see it on his face, but he's distressed. And really, this same thing is happening not only with providers, but it's occurring with, hospital administrators, leaders of ACOs, leaders of medical homes. Everybody is making this transition because we're really, between two models in the United States. I think when you look at, what's gone on with accountable care organizations and patient-centered medical homes and health homes, I think there's really some good things that have happened. I don't know if you know how many ACOs there are in the United States right now, but depending on which consultant you talk to, it's almost 600. And that's a combination of those that are coming through the private sector as well as CMS. And they're saying that that's roughly covering about 18 to 19%, of the population in the United States. So, ACOs are kind of on a growth track. There's a lot of people that say that many of these could fail, and they probably will. Because, to be a successful accountable care organization, you need change management of all the providers. You need a really viable data and analytics system to make them successful. And actually, many organizations that jumped into the ACO world really didn't have that foundation. If you look at the payment models, and Dennis did a really good job looking at these, but you've got shared savings programs, bundled payment programs, global payment programs going on. I don't know if anyone's from Massachusetts, but you've got the alternative quality contract, with Blue Cross Blue Shield, which I think is in probably its fourth year roughly. But at least with that program, they have shown some improvements with quality of care. They have definitely taken some cost out of the system, but it's not a perfect model yet. And I think that's what you're going to find with any of these. We don't know what the best model is. In some of our executive insight sessions recently, people have looked at accountable care organizations and said, this is kind of like value-based care on training wheels. We're trying to learn from the Medicare Shared Savings Program. Just recently, CMS put out a request for information on the next phase of the ACOs. And some of the rumors that we're starting to hear about where CMS could potentially go with this is they really feel that the ACOs that have been successful have had a strong primary care type foundation. And what we've heard is that they're really going to strengthen really the primary care and behavioral health direction on ACOs in the future. Because again, this is the third year of the model, for the first round. So going into next year, there could be another whole ACO round coming into play. We just met with some folks recently that said, actually from Bon Secours, which is in the Mid-Atlantic here, but they said that their best efforts so far, they think, have been with episode of care bundled payments, because they really get everybody on board to see the direction that they need to go with this, and it changes physicians and systems behaviors more quickly than some of the other models. So it'll also be interesting to see where the bundled payments go. There are a variety of performance programs in the United States, and I don't know, some of you have probably seen Patrick Conway from CMS speak, any of you? He has a slide where he shows all 24 of the CMS programs. I'm just showing you selected ones. But the key thing is there are some related to clinicians, some related to hospitals, some related to these new models like the Medicare Shared Savings Program and so forth. What the MAP is trying to do, and I mentioned the Measurement Application Partnership earlier, what they're trying to do is make sure that the measures across all those CMS programs are aligned. And what's been happening that's kind of interesting is that they're trying to align measurements across. Last year, they actually took 78 measures out of the system because they didn't think they were effective, a lot of process measurement. But also, one of the things they're doing in this project in looking at the measures across all these programs is they're identifying gaps in measurement. And that's one of the things that I really want to jump into because, again, we're moving from this process measurement world really to more outcomes type measurement. And I want to show you some of the thinking that's coming into play and maybe how this could be applied to the mental health environment. So, is everyone familiar with the National Quality Strategy in the United States that came out as part of the Affordable Care Act? How many people? Okay. Yeah, this has been one of those things that I think is kind of not too many people have seen, but as part of the Affordable Care Act, Secretary Sebelius, or former secretary, had to come out with a national quality strategy. And what she did is she came out with something that focused on Don Berwick's triple aim that I think most people are very familiar with. So better care, healthy people, healthy communities, which is kind of a population type theme, but then really getting down to affordable care. Now, the other thing that came into play that's marked in red is really the national priorities for quality improvement in the United States. So I was lucky to be on the panel that actually created these, and actually took several years, a lot of debates. There were things that got pulled out. Overuse got pulled out because Secretary wouldn't go for that, and unfortunately end-of-life care got pulled out as a national quality strategy. So, but we were left with making care safer, patient and family engagement. There's some on clinical care, coordination of care, and I think Dennis talked about that, just a little bit earlier. But these are the national quality improvement priorities that are now being driven across all CMS programs, as well as, most private payers have really picked up this direction. What's key about this is that these are now being translated into the quality measurement domains in the United States. I think in the past, we didn't really have domain type of thinking, measurement thinking. There were a lot of, clinical process measures like, you got a beta blocker after you had a heart attack, that kind of thing. That's where we were in the quality measurement world for so many years. But now, Patrick Conway, again, he leads quality at the quality direction at CMS. He also leads the Center for Medicare and Medicaid Innovation, so, those two we think kind of go together. But he came out with an article actually last June in JAMA that focused on really the future of quality measurement for improvement and accountability. Now, in this article, he talked a little bit about the domains of measurement. He talked a little bit about this roadmap for the transition because he said we know we're between this volume world and this value world, and how do we move measurement through that. But he also talked about an agile learning measurement enterprise based on collaboration. And much of this was even based on some of the themes that you've seen in the past from the Institute of Medicine, where they talk about the learning healthcare system. And with especially, listening to the discussion about NetSmart, with something like an electronic medical record system, you have the ability to learn, from practice. And that's really where I think Patrick said we really need to go. The other thing he did is he really kind of codified those dimensions of measurement in that article. So again, safety, care coordination, clinical care, population and community health, patient experience and engagement, and cost and efficiency. So again, this is the direction that's being set now for quality measurement. Now, this is being translated now into the measurement for one of the programs that started to come into play last year. How many of you are familiar with the Physician Value-Based Modifier Payment System? Very many? Okay. So really, this is a measurement program that actually started in 2013 for large medical group practices. Now, those large medical group practices were measured, and in 2015, they'll be paid differently. Now, what will happen is they will have what's called a modifier that will be used times their regular fee-for-service payment, and that will occur for the whole year. So those that were measured in 2013 will have their entire payments for 2015 changed by that modifier. And it's as simple as if you're greater than 1 on the modifier, you make a little bit more money. If you're less than 1, you make a little bit less money on your payment from CMS for the year. Now this year, medium-sized group practices are measured, but really starting in 2015, all physicians in the United States will be measured through this system unless they're in an accountable care organization. And in that case, they will be measured within the accountable care, quality measurement scheme. And I guess the key thing about this is, again, they're being measured on a quality composite score and a cost composite score. And actually, both of these composites are 50% at the moment. So the other thing that's being introduced now, rather, I think, dramatically in this payment model, it's not just the quality measurement that comes into play, but it's now the cost measurement. And I don't know if any of you follow what's going on at NQF, but there are actually 5 different projects now focused on cost. And just in the past 10 days or so, there were 3 new cost measures that were basically a cost for patients with specific medical conditions that are now going through the endorsement process, and it's open for public comment right now. And I'll talk to you a little bit more about this engagement and public comment and so forth. But this is kind of the new type of measurement scheme in the future. Now, the interesting thing is, if you know what the private payers are doing, this type of a measurement framework pretty much fits what they're using in their premium designation programs for physicians. So this, I think in some cases, the private payers are probably ahead of the curve a little bit on physician measurement than even CMS is right now. If you Google QRUR, you can pick up a quality resource use report on the internet. And this is actually the new report card that physicians will be getting in the value-based modifier. And I'm not going to go through all the detail here, but leave it to say that up on the very top you have a quality cost composite, or so you have a quality composite, then you have a cost composite. Down in the chart, you can see it says your group, and there's a red dot. Well, that group actually scored in the middle. Their quality scores were okay, their cost scores were okay. And then what that translates to, see if this works. Oh, okay, right there. What this translates to is their modifier is 0. So their fee-for-service payment for the next year is going to be the same. However, what's interesting is that if they would have scored in the upper right-hand quadrant with their quality and cost measurement, that's high quality, low cost, they could have picked up a 3% addition to their payment. But if they were low quality and high cost, they could have had at least 1% taken away. Now, if you've kind of followed the rules on this program, what's happening is those numbers get bigger, every year, if this program stays in play. So the point is, quality and cost measurements coming into play, and now health systems, but also individual providers are going to have to figure out how to operate in this environment. Now, when I work with a lot of medical societies, what they're starting to look at with this framework is, do we have the right quality measures for our members in play so that they can be adequately measured in this program? And the answer to that is some do and some don't. There are some medical systems ahead of the curve, medical societies ahead of the curve, but there are others that are a bit behind. Now, I think that one of the framework that's really coming into play that I wanted to show you and to think about, both from a practice and maybe a research perspective, is that you can take this framework that I've been talking about already, but you can really add to it and talk about, so what are the individual measurement subtypes that NQF is actually endorsing? And think of these from the standpoint of, what are some research direction that you could take in the future to even help maybe support development of some quality measures. Because again, like I said, we're in our infancy. We don't know what some of the best measurement really is. If you take clinical care, appropriate use as a process measure, clinical outcomes can be like mortality. Intermediate outcomes can be like hemoglobin A1C and diabetes. But also what's coming into play here that's really important is medication adherence, but really more important than that is patient-reported outcomes. So I think NQF, after work over the past 3 or 4 years, has really come to the conclusion that we need much more in the way of PRO use in healthcare, because we really need to understand the endpoint or the outcome from the patient perspective. And that's really going to be key, and there's a lot of energy and a lot of activity right now in the whole PRO realm. Just taking a couple of other things here, if you look at patient experience, clearly the CAPS measurement tool that's been used for a number of years in the hospital is coming into play even with clinicians. If you look at patient safety, I think there's some interesting things here like potentially avoidable complications. This was a measure created by an organization called HCI3 that looks at certain conditions. If you treat people effectively, manage them effectively, you prevent complications downstream. And this is one of the key components of the Prometheus episode of care payment model, where physicians are really reimbursed at a higher level if they can reduce PACs, as they're called. And I think this is one of the most underused quality measure right now, because I think you could build a PAC for nearly any medical condition in the United States, although they've only done about 4 or 5 so far. And so, again, I'm not going to give this all-out look at all of the mental health measures that exist, but I want to show you how these fit in this framework. So, for example, the PHQ-9 measure, and I think that was mentioned earlier this morning, and this was created was basically tested and used up in Minnesota. That's a patient-reported outcome. That measure has been endorsed by the National Quality Forum, so it's really the first PRO that's gone through the NQF endorsement process and now will be used in payment programs in healthcare. So that's a really good direction. Again, there's adherence measurements coming into play with antipsychotic drugs. In the hospital-based inpatient measurement program, there is a measure now directed on, was a care plan created once the individual leaves the hospital. There's now cardiovascular monitoring, for people with CV disease and schizophrenia. So this is actually a HEDIS measure. There's also a measurement coming out of the hospital reporting program on multiple antipsychotics. There's care coordination measures related on follow-up after hospitalization, and on and on. And I think what's really good right now is that, in the mental health area, we've probably gone from like 100% process measurement, in the clinical area, and safety, actually clinical and safety, to now moving to other kinds of measurement in other domains of measurement. But my challenge to all of you would be, how do we accelerate this? How do you build on this, through the research and work that you do? Because, I think, most people still think we don't yet have the right measures in play. In the MAP report, and I think I'm going to show that slide in a minute on the map, but there are some general areas of what would be called gaps in measurement. So the PROs, clearly, clinical outcomes, and I think, at least in the mental health area, that's more of a difficult one to measure than, say, in the cardiovascular world. I understand that. There's measures that could come in place with shared decision-making, and I think that was mentioned at least once this morning. But even looking at this from a research standpoint, there's research that needs to be conducted in the area of shared decision-making just to show what is the impact of a shared decision-making experience on patient outcomes. Does it truly engage the patient to a higher level if you go through shared decision-making processes? I mentioned the prevention of complications. Clearly the hospital readmissions, and there was a comment about that earlier, but overall in healthcare, that probably is the hottest quality measure, and that measure is highly relevant, I think, especially in the patients with schizophrenia. In the measure application partnership, and again, I've talked about this a couple of times, one thing I want to show you is some of their direction on measurement. So these are all those different domains that I've talked about. And what it's showing, a couple of things. One is they want to probably keep some of the patient and family engagement the same. They want to probably expand patient safety a bit. Now, in the effective clinical care, this is still a lot of process measurement, but they do want to, here's cost, that gold there, they do want to expand on cost measurement. So just to show you with the map some of the things that they're starting to recommend. And also what they brought forward, this is from their last report, but these are also some gaps in measurement. But in the area of patient-reported outcomes, avoidable admissions, and then in depression, they actually addressed a couple of different areas. So I think that if you again were to Google the MAP report from January 2014, I think you'd get some key insight on what some of the direction is here. There's a variety of research questions, I think, that are coming into play. Again, taking some of these gaps in measurement, translating that into research direction. You know, some of this related to hospital readmissions, the prevention of complications, and again, this is in more effectively treated patients. You know, what is the impact on PROs in patients with mental health? And again, I think that, you know, the PHQ-9 is going to give a pretty good start on that. The one thing that I hope that will happen with all of you is that you know, you'll want to become more engaged in this world. And I think I just have maybe 2 slides to close on here. But it has to do with there are engagement opportunities with the quality enterprise, and it's very easy to get engaged. So for example, if you look at priorities and goals, well, there's action catalyst teams being created, and there's actually one now in hospital readmission rates. If you take the NQF consensus standard direction, there's new endorsement programs all the time, and actually there's 2 going on, or 1 going on in behavioral health right now, and 1 was completed last year. But there's chances to be on steering committees, to provide public comment, and so forth. So there's a lot of engagement that can take place either with NQF or with some of the other major developers that I had mentioned earlier. And you know, we talk a lot about getting a seat at the table, but it's very easy to monitor these organizations and get a seat at the table, so to speak, especially in terms of either voting or providing public comment. So what I've given you are ways to get closer to a lot of these organizations, because again, I think, you know, where you are, you know, you're in practice, you're conducting research in this area. It's very possible that you're measuring something right now that's very valuable that could turn into a quality measure that you could actually turn into these different organizations. And that was what I wanted to bring this morning.